All right, everybody. We have a fantastic video for you today. I'm really excited about this. We've been wanting to talk to Nick Hanna for a while. Nick, Aiden, and I were actually all co-fellows together, and Nick went on to practice in Tulsa, Oklahoma. He's a very high volume operator there. Nick called me a couple years ago with a crazy case he had with a TAVR that went south on the table. And Nick came up with a really elegant solution to save that patient's life that we're now referring to as Hanna Flow, and it's been replicated hundreds of times, literally saved hundreds of patients' lives. And I'm really proud of him for it. And he had a great post on Twitter, which we're going to reference now. And Nick's going to take us all through the case. So thank you, Nick.
All right, great. Thank you, Joe. I'll just start with a little background on the patient. She was a 93-year-old, very wonderful lady who had aortic stenosis for several years and eventually became rather symptomatic. And she presented to us for her TAVR. And as a background, her family and the patient did tell us when we were consenting her and going through the entire process that they were adamantly opposed to any sternotomy, even if it's life-saving. She was planned to receive a Medtronic core valve. There was no issues with access or crossing the valve. Everything seemed to be going very smoothly. As soon as we crossed the valve, prior to even having any TAVR equipment in there, all that had been in there is a diagnostic pigtail catheter and a safari wire. She became profoundly hypotensive. As with normal times when we think we have hypotension, as we're crossing the valve, we think that we're occluding too much flow in the LVOT and across the aortic valve, so we quickly deploy the valve. And then she still had persistent hypotension, dramatically, completely untouched by multiple vasopressors, multiple boluses of neo, and even some epinephrine. So we got a stat echo. The way we do our TAVRs, we have our echo technician in the lab with us ready to do a surface echo because we have a minimalistic way of doing TAVR as most operators do, and this patient was not under general anesthesia. As you can see with the first echo image, she had a moderate size pericardial effusion that was almost 100% compressing her right ventricle. And so we did find the reason. And initially, my thought was that she had a right ventricular perforation from the transvenous pacemaker. I immediately.
This is
a great image.
So Nick, let's just take us through. So like the patient kind of shits the bed and they have this huge effusion. Are you already getting ready to tap them? Like what is your process for that? Like start with the hypotension.
Yeah, so immediately
differential and then like what you do next. I'm just curious.
Yeah, so on our TAVR cart, we have a pericardocentesis kit, and our TAVR cart is at the foot of the bed with all of our emergency equipment, covered stents, things like that. So as soon as she was profoundly hypotensive, I told them to get ready for a pericardocentesis as soon as I saw the echo. And then once we saw the echo images, we had access to her pericardium probably within 4 to 5 minutes. And I began aspirating blood, and typically I won't start auto-transfusing because I've seen right ventricular perforations and they typically tamponade rather quickly with removing the blood around the pericardium and just giving the patient time and some protamine. This was free-flowing blood as I was pulling it out of the pericardium. So initially, I thought this was going to be kind of a quick fix, so to say, but I began auto-transfusing through her femoral vein, and my echo tech was just looking, could not find any reason why she was having this profound pericardial effusion with tamponade. At this point, I called my partner to come help me. We also have our surgeon in the room, and I handed off the duties of auto-transfusion and vasopressor support to them, and I went out to speak to the family.
That's so.
And basically,
I think we should just like double click on that a little bit because that's something we learned during fellowship, right? When you're in trouble, And when it hits the fan, there's nothing wrong with calling for help, right? I think that's so important, is calling for
Well,
help, different perspectives, someone that doesn't have, a patient they know and on the table, and they can just think of it from such a different perspective. So I think that's brilliant.
oh yeah, and we are a very tight knit group. So if I tell them to drop everything, they come and help. So as I'm speaking to the family, I'm telling them I'm worried she's not going to make it unless we can do surgery, and they 100% said this wonderful young woman of 93 years old never wanted her chest opened. So I told them that I would do my best and I would think of something. So at that moment, I had someone run out to grab me and say the echo tech found something. As you can see in this image, that is a serpiginous left ventricular perforation going through the lateral wall of the left ventricle. You can see it's very high velocity of bleeding, and that explained why we were in the situation.
Crazy.
Our thought was that the safari wire at some point was in the wrong spot, maybe became deformed at some point when we were walking out the pigtail, and that was most likely the culprit. The only two pieces of equipment that were across the valve were an AL1 diagnostic catheter, a pigtail catheter, and the safari wire.
So Nick, backing up, two things. Number one is immediate post TAVR, like really hypotension, burst off the algorithm. For me, it's coronary obstruction, annular rupture, or ventricle perforation. Anything else that you think about?
Contrast reaction.
Yeah.
I've had that happen.
Catastrophic bleeding,
Okay,
like
good.
you tore the aorta or an iliac rupture or something like that. And then
Iliac rupture.
but I
Yeah,
think
that's
those
another
are
good one.
Okay, and then so where we're at here, Nick, you've got a drain, and it looks like that's a bigger drain too, which I think is kind of important. So what size pericardial drain do you typically use on these?
So initially, I use the pericardial drain that comes in the kit. It is that white drain with multiple side holes, and it was just not cutting it. It was clotting off. I couldn't take the blood out and autotransfuse fast enough. Luckily, we still do our TAVRs in the hybrid OR, and so I had access to a lot of equipment. This is a 12 French barred drain that the surgeons use. So I quickly dissected down through her chest and made a large enough hole and was able to essentially surround the entire heart in the pericardial space with
That's
that
huge.
12 French barred drain. And so now the thought process begins. We had already given protamine, and I had already had the idea to try intrapericardial thrombin. I was careful to make this decision because I knew once I began putting anything in the pericardium, I had no more options for autotransfusion. And so I tried to get the pericardium as dry as possible, and then I tried the thrombin. And the thrombin did nothing. It was still free-flowing blood, could not get it to stop. And luckily, I am very fortunate to be in a great group of cardiologists and cardiothoracic surgeons. We work closely together. I will frequently scrub in cases in the OR for my patients or interesting surgical cases. And I remember multiple times they use Surgiflo, and it's like magic. If they're doing a cut down, if they have a lot of persistent bleeding, they put this Surgiflo at the site of bleeding, and the bleeding just stops quickly. Just to give you some background on Surgiflo, it's something frequently used in almost every surgical procedure if they have a need for more aggressive hemostasis. It comes with a hemostatic matrix solution and a thrombin solution, and that is mixed on the back table between two syringes. And the whole point of that is to create kind of a uniform consistency and viscosity to allow you to spread it out over as much space as you can. And at this point, there's a lot of questions. Do you want to put Surgiflo in the pericardium? Is it something that can cross over to the left ventricle? Will she create a huge clot and then go into profound tamponade and you can't pull anything out anymore? At this point, she's on maximal pressure support, already been intubated. I have no other option. And it was either let her die or go for the
Wow.
Hail Mary. And so I decided to put Surgiflo into the pericardial space. And this is an echo image of the Surgiflo going in. It's an interesting, a lot of learning points that I discovered. When you put Surgiflo in, you lose echo windows. And so you put the Surgiflo in, then you don't see anything anymore. So you have to sit there for a few minutes until you get images again. And the pericardium is a very forgiving space in the body, and so I took advantage of that, and I took about 7 to 8 syringes of Surgiflo, which is a lot, and filled up the pericardium. So I had the bar drain in there. I injected Surgiflo because I couldn't exactly tell where the perforation was fluoroscopically. And I injected Surgiflo, then I pulled the drain back, injected, pulled it back. And after every Surgiflo, I injected about 20 cc's of heparinase saline just to keep it moving.
Because the drain will clot off, right, Nick? I've had
and
that
at that
happen.
point,
Like if you kind of have to flush the Surgiflo through, otherwise the drain can clot off, right?
absolutely. And that's why I went with the 12 French, because I wanted to have as much room as I could. The smaller pericardial drains
And what did your
are not
partner
good.
and your surgeon think of this? Because the biggest pushback I've heard on this technique, because interventional cardiologists who have used this and saved patients' lives, they want to talk about it because it's so practice changing. The surgeons have pushed back on this a little bit. I heard Keith Allen at TVT this year really saying that this is crazy. I don't understand how this works. What did your surgeon think? And what's been your reception when you talk to people about this?
No one had a great support or rebuttal. I'll put it that way. Because we had never done it before, and I wasn't about to watch this woman die. And so I made the executive decision to
Big balls, my friend. Big balls. I love it. So let's go to the next slide here on Twitter. So this is on Nick's. If someone wants to look at this, this is on Nick's Twitter handle at heart.hanna. All right, so Nick's got the Surgiflo. He gave eight vials of it, and then what happens next, Nick?
Actually, real quick, Nick, can you tell me, like, what do you think I mean, who knows, right? But like, what do you think in your mind the best way is to, and how much you give? Like, tap it as dry as you can and then just give it kind of fast, or like, what do you
And
think?
that's exactly what I did. I tried to get it as dry as possible. I was pulling back, and because there was already thrombin in the pericardial space, I was just pulling back, throwing away, pulling back, throwing away, and I had the Surgiflo ready. I had the surgical tech right next to me with like 6 lined up. And
So when you create the packet, how many do you get?
well, each box comes with just one, and so they had to go to the CT surgeon's OR and go get it for us, which took minutes.
So when you have a crash cart, you should probably have more than one Surgiflo on it.
So now, when we update our TAVR cart, pretty much quarterly, if not monthly, with just inventory and anything else we think we need, and we have, I believe, we keep 5 Surgiflos on there.
That's awesome.
Cool.
And so, what happened next? It's very nerve-wracking when you fill up the pericardium with Surgiflo, because you can't see anything, and you initially have severe hypotension, and you think something bad happened. And so you just sit there and wait. And then as things kind of settled down, I had my echo tech in the exact same position, and she had a good view of the lateral wall where the perforation was. And I just waited. And after about 5-6 minutes, this is the picture she had. You can see that there may be a little bit. You can see at about 2 o'clock, there might be something that's trying to get out. But you do not see that same brisk, profound perforation.
That's crazy, man. Sitting up 6 hours later. Crazy.
Yep. So and I didn't know what was going to happen. She was still on vasopressors. She was stable-ish. So we came off the table, went to the ICU. We updated the family. it was very nerve-wracking as well because she was kind of a VIP patient with powerful family members. So they were very understanding, very kind family. But she was in the ICU. About 6 hours later, she was awake, looking at us, kind of motioning to take the tube out. She passed CPAP trials. We extubated her. I had the echo tech come do about 4 echoes over that 6 hours. And that picture you saw was the final echo.
Did there ever look like a big collection of this stuff, or did it kind of was it a small, if anything?
Amazingly, it's like we were never there.
Yeah, so it doesn't leave like a big, thick, 2 centimeter thrombin. I mean, fortunately, I have not had to do this. My perfs have been small, and
everyone always asks me if they get constrictive pericarditis, and I don't think anyone's ever seen that. But you didn't see that, did you?
I've done this twice. So my N of 2 did not end up with constrictive pericarditis. I don't see.
It's better than being dead.
Yeah.
When you look at the chemistry of what's happening, when you give thrombin, it's gone. It binds and it's rapidly reabsorbed whenever we use any kind. Think about when you put thrombin into a pseudoaneurysm in the groin. You can't see it after it creates a little bit of a clot. And if you were to ultrasound a pseudoaneurysm a few hours later, all you see is a little bit of clot.
That's a good point.
And so I don't know if it has something to do with the matrix that you're mixing it with that makes it very, consistent. If it spreads out better, I really have no idea of how there was nothing left. But there was just a trace pericardial effusion. And what's amazing is this woman was 93. So we did this at the end of 2019. She's still alive.
Wow.
Great.
That's crazy, man. That's crazy. And tell us about your second one. Did you do anything differently, or had you changed kind of your technique for it, or had it evolved?
The second one was a Watchman procedure. It was probably a small perforation. It wasn't as brisk as that one, and I immediately made the call to try the Surgiflo. That one actually took a little longer because we do our Watchmans in the cath lab, and the TAVR cart's kind of put away down the hall for TAVR days, and that took a little longer to get the Surgiflo, but we did the same thing and it worked. I actually used less Surgiflo in that case.
Wow. Well, I can tell you, man, when you go to meetings and you bring this up, almost everyone I know who does high volume structural work has used this technique and raves about it. I know Dave Daniels has used it a bunch of times, Tom Wagner, they all talk about it. And I think it's something to be really proud of, dude. I mean, it's amazing. I think every cath lab should have a 12 French bar drain and Surgiflo on their TAVR cart. I really do. Because at the end of the day, like you said, especially in some of these non-operable patients, and even in operable patients, there's a 50% mortality for opening patients up. I think it's certainly worth a shot,
Absolutely. And if we didn't think about this and we convinced the family to let us do a sternotomy, she very well may have died anyway.
Yeah. That's amazing, dude. Well, Nick, thanks, bro. I think this is such a good example of like innovation that happens spontaneously in the cath lab that translates into, more systemic things. I mean, single access Impella is one of them. I think it's super powerful. So, dude, thanks for creating this cool technique. And I think a lot of
it was good to hear some of the specifics, Nick. In case I ever get in a jam like this, I feel pretty comfortable now and a little bit more on the technique. So,
and we're hoping to collaborate with some of our colleagues and publish a case series just to get it out there more formally. There's been a lot of community conversations, word of mouth, as you're saying, but I think this really needs to get out to the whole world because cardiac perforation is one of the most catastrophic things in structural heart disease.
Totally. Yeah. Hey, Nick, one last question. There's a move towards getting the cardiac surgical team out of backup for TAVR cases. There's a lot of programs now that aren't even having a cardiac surgical team on backup. Do you think having this technique supports that decision now that this is kind of the last kind of potential utilization for having a cardiac surgical team on standby for TAVR? I mean, what do you guys do at your institution, and what do you think about that?
Well, we have a surgery team with our surgeon, because our surgeons co-scrub in our TAVRs. So it's essentially just his team following him. Now, we've done a lot to mitigate the costs of having a surgical team. We do not prep the pump anymore. We don't even open for free. Frequently, for years, we were opening a cut down kit, a cut down set. So we stopped doing that. That's just on standby as available. I think this is an infrequent complication, but given the strategy of using Surgiflo, I think that you can have the appropriate supplies and the appropriate plan to be able to do it, and that will mitigate a lot of these.
Yeah. Cool. All right, brother. Always good to see you, my friend.